Good morning, everyone. And it's with a pleasure to be a part of this workshop, especially with the eminent speakers with me. Dr. Dinesh Talwar has made my job very easy with his detailed talk on the classification and pathogenesis of AMD. So I will next take you to the patient journey as to what happens once you have seen a patient in your clinic who has AMD. So how do you proceed further? So first question that probably we would like to answer is that, is this neovascular AMD that you are dealing with? Most important, as mentioned by Dr. Talwar also, are the symptoms. The patient comes to you with this characteristic symptoms of scotoma and metamorphopsia. In fact, you cannot miss the metamorphopsia. This is one of the earliest symptom, and not only the symptom of disease, but symptom of activity. You will see that as long as metamorphopsia persists, usually the disease is active. In addition to it, other family history and systemic history will also be useful. So it is best to elicit also at this point of time. A comprehensive eye examination at the first visit is a must. A stereo biomicroscopic examination can help you, at least you know what you are identify what you are looking at, and probably it will give you some idea as to which investigation we would like to do. And Dr. Drais has already mentioned us the whole long list of investigation which is available for these patients. But after your examination, you can choose which one will be most apt. You may not always need to do all of them. For my patients, what works well for me is that fundus examination, a fundus photograph at baseline, and of course, OCT. OCT is necessary at baseline, and these are the few typical features of AMD which will be seen on OCT. You could have fluid in the subretinal space, or you could have these serous PEDs, or you could have fibrovascular PED, as was explained by my previous two speakers as well. All these are features of neovascular AMD. Third question is the disease active? Because you could have patients who have scars due to AMD, so you don't go ahead and treat them, or you could have intermediate AMD or early AMD as was discussed by the previous speaker. So you want to know whether this disease, which is AMD, does it need treatment or not. Most important is presenting BCVA. So if there is a recent loss of at least more than 5 letters, you know that this is an active disease that we are looking at. New subretinal hemorrhage and presence of fluid on OCT that we'll see on the subsequent slides. Only one thing that I would like to highlight, that though a drop in vision is the most present classic symptom of active disease, but you could have patients who have vision as poor as 3/60, and they have large membranes which have been there for a long time. You need to be sure that this is a recent progression of diseases there before you go ahead and treat the large lesions. On the other extreme, I would mention that even if the patient has 6/6 vision, you would definitely treat if there is an active neovascularization. So most important biomarker of disease is fluid, and this would probably be discussed by subsequent speakers as well. But you could have fluid in almost all 3 compartments. As was seen here in this slide, you have fluid in between the neurosensory retina and the pigment epithelial detachment, or you have it below the pigment epithelial detachment, or you have intraretinal fluid, which is within the neurosensory retinal layers or within the inner retina. So subretinal fluid is the most common, and this is usually seen along with the type 1 CNV, which Dr. Dinesh explained earlier, which has its seat below the RPE, and the intraretinal fluid can be seen in all forms, but usually is a presenting feature in cases of type 2 or type 3. A type 2 membrane, just to revise, is above the retinal pigment epithelium, and type 3 arises within the retinal space and then goes down. Just a thing to remember, that sometimes you can have these large cysts which can be present over these disciform scars. So these large cysts vis-a-vis IRF, which are small tiny cysts within the inner retina, they may not always represent activity, and these could be signs of a degenerative retinal cyst. Fourth point, look at the size of lesion. If it's again a very large lesion, more than 12 disc diameter, think about therapy, because it's a long-term therapy. The visual outcome may not be great, but in the evidence of a recent disease progress, you may still think of treating. Associated risk factors, especially smoking, which you have to encourage the patient to stop, and history of cardiac disease, history of stroke, because minimal increase in risk of stroke and cardiac disease is seen in anti-VEGF patients who are taking anti-VEGF for a long time. But this is should not warrant against the treatment. You rather can be in consultation with the cardiologist before you initiate any therapy. Next step for me is the classifying the age-related macular degeneration, the type of CNV, whether it's type 1, type 2, type 3, or most importantly, PCV. So this, as I mentioned, type 1 is below the RPE, type 2 is above, and type 3 within the retinal surface, inner retinal layers, and grows downwards. The importance of these things, whether it's type 1 or type 2 or type 3, though the treatment is still going to be in form of anti-VEGF injections, the importance is that if you have a type 1, usually the patient presents with good visual acuity, and they may maintain visual acuity for a long period of time if treated well. But if not treated well, they lose these visual gains over a long period of time. And collapse of type 1 CNV can cause geographic atrophy. Type 2 are more prone to form disciform scars, and type 3 are actually highly responsive to anti-VEGF therapy. But again, you may limit the number of anti-VEGF injections in these eyes because increased risk of GA has been attributed to type 3 lesions. And if you see PCV, you could consider PDT and not just a monotherapy with anti-VEGF. So this again, as I just mentioned, whether you're going to do monotherapy or combination, in cases of extrafoveal thermal laser, as was told by the previous speaker, and PDT for subfoveal lesions only when you see patients with PCV. Usually, steroids do not form a mainstay of therapy in neovascular AMD, but certain specific conditions at all you could consider. Anti-VEGF is the monotherapy, is the gold standard now in this era for neovascular AMD, and it has been shown to preserve vision, to improve vision, and maintain long-term visual gains. The next is treatment protocol. So ideal would be you give it to do the treatment once and you're over and done with, but that doesn't happen. So you have a treatment protocol. You give 3 monthly injections in type 1, type 2, type 3, most of the times, though of course at 1 month follow-up you evaluate the patient. And if you have no response, then you think whether you're going to continue it or you need to switch it. And if you have the lesion is absolutely dry, you may consider either observe and extend or treat and extend. And if the response is there but not completely dry, you can go towards treat and extend treatment. So despite all these things, the lessons learned are that most of the patients do need treat and extend, and they should not give up just after a few injections. So this is where the patient counseling is most important, that you should counsel the patient in the first sitting itself that this is not a single time treatment. Unfortunately, though subfoveal CNV because of neovascular AMD is amongst the top diseases which affects the quality of life in patients, but the amount of know-how or knowledge is very minimal. Regular screening protocols for patients more than 50 years of age are not present, and it comes as a bolt from the blue when the patient suddenly knows that he has this problem, and then you have to tell the prognosis, the potential value, the kind of treatment, monthly follow-ups, extended follow-up. All this has to be explained to the patient, and lifestyle changes also. And not only the follow-up, but to tell this about the symptoms which can cause a drastic decrease in vision, especially when we are giving intravitreal injections, which is an invasive form of treatment. So follow-up is also equally important. Again, record visual acuity at every time, do a stereoscopic examination, and then you do almost OCT may be necessary every month. FFA only if PDT has been done, then you may consider once in 3 months. And if you have done thermal laser, usually best time to see is about 2 to 4 weeks whether your thermal laser is adequate or not. And once you have initiated the response, how do you know whether the patient is responding also or not? So you could have functional parameters, morphological parameters, or a combination of the two. So usually what I look in the functional is the response at 1 month. You can also see the response at the end of 3 months of 3 loading injections, which means the response at 4 months. So at 1 month, if you see that there is a more than 5 letter gain from baseline, which is a very good response. If it is 0 to 5 letter improvement, which means it is a partial response, or if there is no change, then it may be a poor response. And non-responses, as I said, that you could have a drop in visual acuity actually. So usually, though this can give you some idea at 1 month, but that does not mean that you should stop the treatment if it is not responding. 3 loading injections are generally advised. And then you look at again, a functional response at 4 months with a similar criteria. Anatomical or morphological responses are seen at 4 months, and you could have patients who initially respond well, but then do not have a good response, or you could have patients who initially do not respond, but may gain 4 to 12 months later, which is a late responder. So it is definitely worthwhile to keep the patients on these monthly injections for at least 3 to 4 or up to 6 months. So morphological response is seen on OCT. Good response is reduction in fluid by up to 75%. And if you see that there is a less than 75% response, then it may not be a very good response. And if there is worsening, then we call it a non-responder. So primary failure is judged usually at 1 month after the 3rd injection, and secondary failure is anytime after 6 injections. And recalcitrant CNV is something that after 6 intravitreal injections also, the patient does not respond. Only then you are justified in calling it a recalcitrant CNV, and that too 6 monthly injections. So a proper protocol, if it has been followed for 6 months, then only if the CNV does not respond, you label it as a recalcitrant CNV. Once you see that there is inadequate response, I think this is the time to reevaluate and usually look for if any other cause is there. And most commonly, it is sometimes PCV, in which you need ICG to establish your diagnosis. Other common causes which could masquerade a neovascular AMD include CNV because of CSCR, vitelliform disease, post-uveitic CNV, or MACTEL. So what happens if you have inadequate response at 4 months? Do I switch? Yes, at a primary failure at 4 months, you could consider switching or continuing with the same anti-VEGF after 6 months, after which again, you can take a call whether you need to switch the anti-VEGF or not. Another term which is usually used is called the treatment pause. Treatment-free period is usually given when after a long time you feel that the patient is still not showing too much of improvement. You stop the anti-VEGF for a while and see that after stopping, is the disease worsening? So if the disease is worsening, you know at least some effect the anti-VEGF was having. So you continue with the anti-VEGF. But if after stopping the drug also there is no worsening as well, then obviously in the recent Retina Journal in 2020, this lesion has been described as a futile lesion, in which case you can consider cessation of therapy. So aim of treatment is not only to give the injection to improve vision and stabilize and help the patient maintain these improved visions for a long period of time and individualize these treatment regimens. In patients who are not able to regain 100% of their vision, especially in bilateral AMD cases, visual rehabilitation plays a very important role, and this definitely must be offered to the patient. Follow-up of the fellow eye is extremely important. You could see this ARED score and you realize that even the drusen or presence of a CNV on the other eye can increase the risk of development of advanced AMD in the fellow eye as well. And you may have to offer the patient regular monitoring as well as AREDS2 supplements. In spite of very good treatment, we still have many unmet needs. The most important is the need for multiple visits, multiple OCTs, and we need definitely long-term formulation, sustained delivery devices, and topical or oral therapy if could be devised. The need for this invasive treatments every month can be reduced. For me, I think the home OCT monitoring can be very handy, especially in this COVID era, that you could not, the patient, you can reduce the number of visits that the patient comes. And if combined with deep learning, you could have the machine giving you the answer, whether you need to go to the office or to the hospital for the injection or not. So with that, I end my presentation for now, and we go on to the next one.